Okay. So like I just said earlier, the main purpose is to allow you some space, some protected time for you to think about the experiences that you've had through the later stages of training, and think about this transition that you're going through into being qualified, and to help with the sort of development and that transition process within that. This is very much your group, you know, we really want your involvement in it. We want you to help shape it. So for today as well, please chip in, use the chat function. I just discovered that you can have a blue hand raising on the participants button, which I only found out about last week. Use that if there's anything you want to say, or unmute yourselves and just call out as well. That would be really helpful. And we'd really like to hear your ideas for any future events, the kinds of things that you'd like to see that we can help facilitate in that way. Okay, so this is a run through for the session this morning. We're hoping to go through till about 1 o'clock. So kind of some approximate times there. But the first bit is Geeta's going to be talking and has got a short presentation about clinical psychology and the profession. And then we're going to go into some small group discussions about challenges, surprises, positives about the transition that you've been going through. Then a short break. And then we've got 3 early career psychologists who finished training in the last 1 or 2 years that are going to come and talk to you about their own experiences. Then a further break, and then some thinking in small groups again about ideas to take forward, kind of where next, what might be helpful for me, and then feeding into this group and about the sorts of things that you might like to see going forward. Okay, so I'm going to introduce Geeta, who has a number of great titles to her name. So she's got them listed there. And again, feel free to comment, question. We'll collate questions, use the chat function, call out, and we can kind of gather those together at the end as well. Okay, so I'm going to stop sharing and then hand over to Geeta, who can share.
Hey, thank you. Right, now I closed a whole load of windows so I could find the right one, but I think it should be that one. Let's try. Can you see that? Okay, I'll go go into slideshow.
Yeah, we can see that.
Is that okay?
Yeah, that's good.
So, yeah, so I'm Geeta Bhutani. I've got a load of job titles. I think probably the reason I got asked to do this was probably a lot to do with my Psychological Professions Network hat on. So within the Northwest, we set up the PPN about 6 years ago, and we're now in the process of setting the networks up across the rest of England. So there's one in the southeast, there's one in the southwest, and there's one being set up in the Midlands, one is being set up in northeastern Yorkshire and London, and we're in the process of recruiting for a chair for the east of England. So that's actually really, really exciting. So I'll say a little bit more about that later, but if you're not a member, I'd join because it doesn't cost you anything, and we're running a conference which was going to be a face-to-face conference in a nice hotel in London, but strangely enough, that's not going to happen. So I think probably makes it easier from an access point of view. It's actually all online, and it will be on the week of the 16th. So I was asked to talk about the transition from to being a newly qualified clinical psychologist, as well as some other things around the sort of challenges for the psychological professions. And I thought, oh, well, that's a very long time ago, because I did my training a very long time ago. And I thought, well, am I actually really the right person to ask about transitions? And I thought, well, actually, we all do transitions. And one of the things that's kind of come up as a question in my career over the last sort of 20 odd years is, now that I've done this, it'll all make sense, won't it? So I didn't know whether this was a theme for any of you so far or not, but you know, does it all make sense now you're qualified? Well, you can think about that later. So now you're a clinical psychologist, what's actually happening? So you've got all this responsibility, well, sort of, and you've got the autonomy because technically you are in charge of your own caseload. You haven't got, you know, the responsibility of a clinical supervisor to say, right, yes, you know, I'll help you with this. Though there are people around. You've got all this knowledge. you've got a fair bit of experience, but there should be support around. And I mean, again, I don't know whether this resonates for anyone, but one of the things I certainly remember from being newly qualified is having this real anxiety about buying a load of books, reading the first 2 pages, so I actually knew what to do in terms of an assessment because I didn't feel I'd learned enough, which I probably had, but it made me feel better. So I think we probably all do that kind of imposter thing quite a bit. But what else is happening in terms of being newly qualified? I think depending on the roles you're in, you could be in a multidisciplinary team. There could be something about being perceived as the psychology expert in that team, which probably might feel a bit odd. And then there's also the perceptions of other people in that team. And I suppose a couple of examples for me is, do service users look at you and sort of think, not all newly qualified psychologists are, young in chronological age, but many of you are, and many of my cohort were at the time. And so I suppose when I started working with older people, I think sometimes they kind of think, well, who's this young person to actually sit there and tell me anything, because they've got no life experience. So there's something about how do you manage that kind of credibility bit in terms of other people's perceptions of you. And then there's a thing about staff from other professions. When I started, I did a split post working in adult primary care and working in an older person's inpatient unit, and they hadn't had a psychologist in the inpatient unit probably ever. And one of the things was just working in that unit, I wasn't entirely sure what I was supposed to be doing or what I could offer. And the thing I used to start sort of wondering about was colleagues saying, well, we've got a real challenge for you, Geeta. Thinking, well, actually, have they got a challenge for me? Or are they just trying to wind me up? Or what exactly is that going on here? And then I think there's also the perception of your fellow or more senior or more experienced clinical psychologists and their views of you. And I don't think they're always as positive as they could be. So, and I don't know whether that's an experience you've had, but how you manage those perceptions and relationships with other people as well, because you are qualified, you've got a perfect right to be in that place and, do what you can. But, like most of us, you won't know everything, because I certainly don't. So how do you find your way? I guess it's that sophisticated skill set you've got. Pretty good at listening to lots of people, supervisors, service users, other professionals, Lara, Joe, and Katie, in terms of what you've learned over the last 3 years. You've got a pretty sophisticated set of formulation skills, which is different from many of our fellow professional colleagues. And you've got a lot of reflection techniques, because that's kind of part of the way we work. And I think probably one of the things I've sort of learned over many years, and it keeps coming back to me, is those things are so important. They're transferable skills, and they're transferable things that you can do in every setting that you're in, whether you're with a service user or a patient, whether you're with your team or fellow colleagues, or whether you're sitting in a management meeting and thinking, why are they all arguing about this? All those things just really, really help make sense of that landscape. But I don't think we should forget the support aspect wherever we are in our careers. I think peer group support, and I know this session is hopefully a start of that, or a continuation of some of that for some of you. Professional supervision. Some of our roles can get very isolated. Some of you might be the only, clinical psychologist in that particular area. And it's easy just to get so busy that you don't have the time to do this. And mentoring can be really important, just in terms of having that space to think about, well, what am I doing here? Before you get, otherwise it's so easy to get bogged down with the demands of the day job. And there is a bit of a loop there in terms of taking the time out, in terms of that listening, formulation, reflection can help, manage the transition, manage the development, consolidate what you know. So those are my kind of reflections on a transition to being a qualified clinical psychologist. Hopefully they're helpful. Again, happy to pick up some questions later on that one. The rest of it, I was just going to perhaps provide some kind of background and context information about the sort of challenges, I suppose, and opportunities facing psychological professions. So we're a pretty small group. in terms of psychological professions. It's about 20,000 of us at the moment, with approximately, well, just under 10,000 are clinical psychologists. But the long-term plan, the NHS long-term plan, has proposed an expansion of psychological professions in NHS care by about 70% over the next 5 years. And that's great, but it's also very challenging because I'm not quite sure how that's going to happen. And I think what's really good is the demand. People want talking therapies. If you ask any service user, audit, survey, whether it's a community mental health team patient survey, or whether it's any other area, whether it's in terms of clinical health type work, people want talking therapies. They want to have access to that. They don't want to be only given medication. Sometimes medication is appropriate. And I think that's positive, but it's been quite hard to respond to because we're such a small group, whether we're as clinical psychologists or as 20,000 psychological professionals. For example, there are roughly about 20,000 midwives in England and Wales. As another example, there's between 40 and 50,000 junior doctors. And and there are more nurses in the NHS than any other profession, which is understandable and not necessarily, that's quite right. But we're a very small group within that. If you look at the allied health professions group, there's about 160, 70,000 of them across all their different professional groups. So, we are very small, but we have a very specific offer in terms of what we do, and people want it. And I think, again, the impact of COVID, despite its challenges, despite all the difficulties and the negative impact it's had on people personally and professionally, it's really also brought a demand for psychological input to the fore as well. When you have NHS England setting up helplines and virtual common rooms and asking for help from professional bodies and clinical psychology trainees in different parts of the country to run services for staff, then that is actually a recognition of what's really, really needed. And that's a positive thing in terms of being able, unfortunately for a negative reason, but we should make the most of that positivity in terms of actually being able to get psychological approaches into even more mainstream than we might be. So got a picture just to show you what a 70-odd% increase actually looks like. So going back to 2007, those 10,000 people were probably pretty much all clinical psychologists with a few hundred cognitive behavior therapists and counsellors. And then IAPT came along, which is somewhere about here. And then that's where we're supposed to be getting to. But that will probably be a challenge. But who are the psychological professions? So there's 12 that are currently included in how NHS England counts things. And that is primarily to do with the main professional groups that provide publicly funded psychological approaches. And broadly, practitioner psychologists, so clinical counselling, health and forensic, psychological therapists such as cognitive behavior therapists, counsellors, child and adolescent psychotherapists, systemic and family therapists, psychological practitioners such as psychological wellbeing practitioners, children's wellbeing practitioners, and emotional mental health practitioners, which the last two are new roles. But we're all pretty different. We all do similar things, but practitioner psychologists are the only groups that are subject to statutory regulation by the HCPC. The other groups, some of them have accreditation bodies like the BABCP or the BACP, and others don't have anything at all, but it's a work in progress. So psychological wellbeing practitioners do not have an accreditation process nor a professional body. It's probably pretty fresh for some of you. Entry points into any of these professional groups are completely different, not always open to everyone, and probably pretty confusing. The training requirements for each are very different. So if you happened, not that you will now, obviously, but if someone happened to decide to go and train as a psychological wellbeing practitioner, qualify and thought, well, that was really good. I've done that for some years. I've kind of consolidated it. I'd like to do something a bit different. They would have to start again in terms of becoming a children's wellbeing practitioner. They could go on to become a high intensity therapist, but they could apply to join a clinical psychology training route. But there might be challenges about getting onto training for family and systemic therapy, for example. which maybe isn't that helpful in terms of thinking about how we create career paths and broaden our approaches, across our groups. So I think within clinical psychology, in some ways, we're quite privileged because there is a career pathway. It's perhaps a set of stepping stones rather than a clear line, but those opportunities are there because the pay and the banding structure is there for us, which it isn't for others. Excuse me. So not going to actually ask anyone this but within our group of, say, 12 psychological professions, we can't always articulate the differences and similarities. We don't always know what exactly is in the curriculum for a family and systemic therapist, how long it takes to train and what you do afterwards and how much you might be paid. I know bits of that and I have actually looked into it. So can we really expect our colleagues, patients, service users and public to do so? So I think there is something about how we, I suppose, explain what we do, but explain it in an inclusive way, as well as being clear about there are times when you might want a clinical psychologist rather than a cognitive behavior therapist, and there are times when you might not. That isn't necessarily about devaluing our professional group, but it is about being clear about what the role is and what you want. And sometimes people just don't know. They don't know clinical psychologists do a lot more than therapy. They don't know that cognitive behavioral therapists do quite a range of things in relation to CBT across the lifespan. So it's an ongoing issue. And I think that can present some problems. And that was partly why we set up the Northwest PPN, is to try and come together as a group of people to try and, I suppose, educate, influence, and inform what we do, people about what we do. And I suppose one of the things is how we do that is thinking about, well, what's important to us all. So these are pretty standard things. I don't think anyone would necessarily disagree with them. But if there are a set of principles we can all sign up to, then maybe there's an opportunity for us to work better together in terms of improving, the availability of psychological approaches for all. So the other thing I was also asked to do was talking about mental health and service provision. And I thought, well, that's some of you will know more about this and have more recent direct experience with this than I will. But I thought one of the things that was perhaps worth highlighting, because all this stuff you're probably either aware of or you can actually look at, is probably for the last 10 to 12 years or so, roughly since IAPT came along, we've been operating predominantly within adult mental health, with some, I suppose, inclusion of older people's services, though that will probably vary. But the idea is that the step care model provides the right intervention at the right time and it's the least intensive intervention that is appropriate for that person at the time. But you've probably all heard that there are some challenges with that. So the idea is that, at steps 2 and 3, you have improving access to psychological therapy services. At step 4, you would have secondary care mental health. And at step 4, 5, you'd have acute inpatient or crisis services. But then you have other things like liaison mental health or tertiary specialist services like the one I work in, which is a complex post-traumatic stress service. But then there's the gaps. So we have people that don't really fit into a time-limited psychological intervention like IAPT offers, but they don't really fit into the current definitions of secondary care mental health because they don't have risk issues or a need for multi-professional inputs. And then there's challenges around comorbidity. So if people have long-term physical health problems, they might fit into some IAPT services, but they might not, because IAPT is still quite limited in what it offers across the long-term conditions pathway. We've had debates for years about whether people who have difficulties with addiction need to resolve their addiction before they actually access mental health services, which seems quite ironic given the fact that the addiction is often, or the use of substances is a way of kind of managing those mental health problems sometimes, but we don't seem to be that good at doing a coordinated approach. And cognitive impairment. And I mean that in its broadest sense, because, whether people are, perhaps in the early stages of dementia, or whether they have learning difficulties or disabilities, but on the mild end, so should be able to access mainstream services, or whether there are sort of brain injury difficulties, how good are we at, and from a service level, at making those individual adjustments for people to access our services? And then I think some of the stuff that's starting to come up is the literature and the discussions around long COVID and what that actually means. I think it's too early to say, but there is something about that thing about early assessment may help people's recovery a lot better. But I'm not quite managed to get into those conversations as well as I could. And then there's the gaps around working with systems and communities. Colleagues, there are colleagues across the country that do perhaps more community-based work, which is more preventatively focused. But I think often within our NHS services, we get very focused on reacting to what people need. And we have less space and time to think about how we could work across the piece. But given the fact that our services are being, I suppose, set up or commissioned in the future to work a lot more closely with the third sector, it's possibly an area for us to think about how do we work with them. We may not do an awful lot, but in terms of having those contacts. And then there's staff. So those of us who work in teams, we might find ourselves doing staff support on an informal basis. And I think COVID's brought the need for more formal support to the fore. That's partly mental health, probably not all completely mental health. And I suppose going back to should mental health sit in isolation, it cuts across the piece. So again, population health, which I sort of touched on. One of the things that's so I qualified a long time ago. And one of the things I always wanted to do was a bit more around mental health promotion. But even today, mental health promotion focuses predominantly on smoking cessation, obesity, exercise, alcohol use, and not an awful lot on wellbeing approaches. There are exceptions, like 5 Ways to Wellbeing, but a lot of the really the stuff for us which is more focused on psychoeducation is not about complex formulation, doesn't seem to be that well known or as well known as it could be. So a while ago, I was asked just to support, it was an asylum seeker and refugee registration, GP registration thing. And I was said to my colleague, well, what do you want me for? Who's going to want to talk to a psychologist? And I was quite, I suppose, slightly embarrassed and humbled in the sense that a lot of people did want to come and ask me about sleep or wanted to ask me about post-traumatic stress. And the answers and the information I was giving them was from the point of view of a qualified clinical psychologist, quite straightforward and quite psychoeducationally focused, but it just wasn't out there. And that seems such a shame in terms of, if a lot of that was out there, it might make the work we do more focused, more efficient, more targeted. And I think that also links into the increasing recognition of communities in place in terms of how our NHS and healthcare is being set up. And there's a lot more happening in terms of support and choice and self-management. Are we as user or patient-led as we could be? Do we have those partnerships with the third sector? The NHS is very good at deciding who comes in to access its services and perhaps less good at looking at what those transitions are for our service users and patients. So some of the challenges, there may be opportunities in there too. So I suppose I will stop very soon because I think I was told to have 20 minutes and I'm at 20 minutes and 42 seconds. I just wanted to bring us back to the beginning in terms of thinking about our skills as clinical psychologists. So, and I think, listening, formulation, reflection, I think those are our headlines, but there's all these other things. This is stuff that we all do and that you all do. And it's worth just thinking about how you do that. And also thinking about what do we need to be able to do. So there is something about understanding the landscape and the pressures within the NHS. To be able to write a good business plan is a skill worth having. Most organizations have templates about what they do, but they're all pretty much the same, which is, why do you want to do it? Tell us within our framework why it's a good idea, how much it's going to cost, and so on and so forth. But it's a good, useful thing to have, and useful thing to have those in your kind of back pocket if there's an opportunity that arises. I think, a good evidence base is something that you will have covered a lot in training, but just understanding how things like NICE work, how the evidence base has an impact on our population and the services that are commissioned is useful. And that link to health benefits analysis. Now, by no means do I know anything much about health economics, but just understanding the principles of how it works is actually helpful in understanding how the NHS works, because I mean the NHS works on the basis of, you know, the most cost-effective way of providing as much healthcare for the many across the board, which is why NICE costs things in the way they do, and why things are calculated on the basis of quality of life measures or years of health gained measures. And just understanding that, not necessarily doing it, can just give you some language which will help in terms of that. Care pathways, you know, things that you probably have covered, co-production. And I think thinking about, you know, as newly qualified, what is it that you already know and can contribute to service development within your areas, or national guidance? You know, the special interest groups within the BPS and other professional organisations do want input to help provide guidance for their members. And I think linking into that, how you influence as a clinical psychologist, some of these things may not be the right time for you, but there might be things just to keep your eyes open in terms of what professional bodies are doing, what your local system is doing, and thinking about co-production. Is that something that, you know, working with service user and carer groups, that can be an opportunity as well? And I don't want this to sound like you should be doing all this stuff, because to be honest, this is what, November. And for those of you who started and posted in the last month, it's pretty early days, but I think it's more about, don't forget this stuff. You know, it's not the right time. Come back to it next year, but don't forget that all that stuff is out there. Just keep buying the books and reading the first 3 pages. That's what worked for me. So again, this is a reminder, just I guess, for you to think about what can we actually bring in terms of all the things that we can do. So high quality clinical interventions, psychometric, supervision for other professional bodies, service developments, staff wellbeing, Schwartz rounds, governance and assurance, evidence base. You know, if a research opportunity comes your way and that's something you're interested in, I'd grab it. Because the more you can get it consolidated early on, the more that it's easier to hang on to some of these things. And I'm sure, I suppose Lara, Jo and Katie will no doubt be thinking about who's going to help deliver some training for the courses in the next few years as well. So wouldn't forget that bit either. So thinking about how you go forward and that transition, how's your experience so far helped you learn, refine, develop your skills? Where's your leadership come from? You know, you've probably done things as service development projects or audits, and that has been you leading something in terms of being able to develop that project, feed it back to the team. And, you know, those ideas around distributed leadership, we all have our roles to play. And how do we apply our evaluation and analytics skills to real life scenarios? And I think, again, going back to the beginning, formulation, the application of psychology. So some questions. Ones for you to think about or ignore, or think, oh, I'm not doing that till next year. That's fine. But just don't forget them. So in what areas? What are you interested in? Where are you curious? Who can you find to talk to that's going to help you about some of these things? So I just wanted to flag this, that, you know, I trained a long time ago and it's over to you. I don't expect to be sitting here in front of whoever qualifies in 20 years time. I'm hoping I'll be sitting at home quietly doing whatever I want to do and retired. And if I do need a clinical psychologist, you guys are going to be organizing the services that I can access. So in 20 years time, you'll be shaping these services. And how are you going to do that? So no pressure. But the next 20, 30, 40 years are ahead of you, and all these opportunities are there. But you don't need to do it all now, so don't panic. So I will send the slides out. I had to reassure Lara, Jo and Katie that, yeah, there are 46 slides in the slide pack, and I've left them all in because I wasn't going to cover them today, because they have a lot more detail around the structure and PPN and things like that, but they will be circulated for you later on. So I'm going to stop 6 minutes over time. Thank you. Shall I stop sharing? I'll stop sharing.
Thanks very much, Geeta. That was really interesting. I liked the sort of circular nature of it as well, really thinking at the start about support, supervision, peer support, mentoring, and then thinking about the much broader picture about the profession and service provision, and how important some of those other things will be to scaffold those skills and that development going forward. So that was really great. Does anybody have any questions for Geeta?
Put you all off.
I was just going to ask, with the PPN, is there any plans for there to be a similar sort of thing in Wales?
Not at the moment, as far as I know. I mean, I know they were interested in it, and certainly I think, some sort of, I suppose DCP colleagues have asked me about it, but at the moment they haven't. And I think it's possibly their structures are slightly different, but there's nothing to stop, anyone who's interested, making contact with me or Adrian Whittington to say, we'd like to do something similar and looking at how they could develop it. We'd be happy to support that. I think we've not expanded into Wales because we don't really have a mandate to do so. Because NHS England is NHS England, as opposed to NHS Wales. But if it's a model that would be useful in Wales or anywhere else for that matter, then, absolutely happy to share.
Thanks.
You could start it off, Emily.
Yeah.
That's the point.
I had a question, Geeta, because obviously as programmes, we're in the midst of COVID and the impact of that on teaching and everything, and then also thinking about the increase in commissions that we've got and that rolling over to next year, with either a similar increase in commissions or even more increase in commissions, which obviously contributes to that graph that you showed, which is great. But it's, we've got obviously concerns around placement capacity and supervision availability and all of that kind of thing. What are your thoughts about the impact of COVID on services going forward in terms of what might be kept and what might be lost and those sorts of things about how things are delivered?
That's a huge question. Kept in what way? I mean, in terms of service provision or the whole outline of a service in terms of?
I suppose because we're seeing that services can be provided in blended ways, aren't we? The usefulness of these remote platforms and things to deliver therapy, to have supervision, that kind of thing, obviously for us to deliver teaching. And I think as much as we maybe rail against it because we don't like it and we love that, the face-to-face and the connections that we have, there's elements of it that are really useful and that we may keep in terms of education providers. So I'm just wondering about your thoughts in terms of service provision, what the kind of longer term impact of COVID, and things that might be able to be kept hold of that will be positive for the provision of psychological therapies.
I think it's probably too early to say. I mean, I think that there's probably, similar views in terms of, some things that are good, some things that are not. I think the challenges within, I suppose, the provision of sort of psychological therapy services, IAPT, for example, is, okay, perhaps most or some people can access digital channels and that works quite well for them, and you can do a lot of things on digital channels which works okay, but not everything. So there are a proportion of people, and I know I was talking to Claire Maguire about this, so I know this isn't just my trust, who have said, well, we want to see you face to face, so we'd rather just wait in the waiting list until we can. And that's going to create additional demand and perhaps some challenges around managing a group of people that just want to wait to be seen. And what do we do about that? And I don't think there's been a kind of a clear idea of how we manage doing that. I think there's also people, so where I work in terms of I suppose complex PTSD services, there's a couple of people I have contact with, and one of them was shielding, and there is no way that she could cope with the conversation about her traumas because it gave her nightmares for about 3 days. So we ended up talking about gardening for about 12, every couple of weeks for 12 weeks just to keep in contact, or cats, anything just in terms of maintaining contact. And there will always, I think, be people who are in those types of groups or have had those types of experiences that make it really difficult. So I think the good stuff is, it's more accessible for lots of people, but the bad stuff is it doesn't work for everyone. And I think there is something about working out a more sophisticated approach about how we manage that. And I think we're also forgetting that, the same things that have come up in education is that not everyone has access to a smartphone and not everyone has access to, a laptop that will do Zoom or anything else. So how do we support those people that are digitally poor or digitally unenabled or whatever the phrase is? So I think that's the bit that probably worries me, is how do we make sure that people can still have those inputs And then the other one, which will probably have come up, is I don't think we've resolved the neuropsychological assessment aspect in terms of doing that in a either head to toe in PPE, or can you do it remotely, and its impact and validity, and all those people with communication issues that really can't function with masks, communicate with masks that cover the face or half the face. So I think there's still a lot of challenges, and I think we can work through them, but I think sometimes our structures aren't as flexible as we could make them, and we've still got to deal with that. So
I think it's raised interesting questions in terms of it's different if you work in mental health, isn't it? That all the psychologists do one thing and it's remote, it's mainly remote. I've noticed a real difference, say, in the Facebook groups nationally, but if you work in physical health, it's raised interesting sort of professional questions about how do I, as a psychologist, justify not going out face to face when a lot of my colleagues see that as just routine. And I know there's something about, I can probably deliver my service more easily on the telephone than a physio can, obviously, but I think it brings up interesting questions in an MDT about how are we similar or different to our colleagues as well when we're in physical health settings.
I think that's absolutely true. I think context is so important. So I mean, I was talking to a colleague that works in the local acute hospital, and she was saying she works major trauma. She went back in, the whole head to toe PPE, and I think there's a challenge there in terms of, how do you retain being part of a team, and maybe your role requires you to do that, but then there's also the other bit of that, which is I think we all need to think about our own individual risk assessments in terms of and the expectations on us, whether we're psychologists or anyone else, about what we think is reasonable for us to do. So, I don't have a particular problem going into work and seeing people, and have worked through that risk assessment for myself, but it isn't the same for everyone. It isn't even the same for everyone in the service I work in. So
I was wondering whether people, what I really liked about your presentation, it's a good reminder at the start of Qualified Life about the breadth of the role, isn't it? That and I wondered whether people are seeing that breadth in what you're being asked to do now in the first 2 months of qualifying. Maybe you could stick it in the chat function, or just turn your microphone off and just chip in. Like, what are you seeing that breadth? Are you being asked to do the range of roles that Geeta's talking about, or does that feel very different from the tasks that are on your to-do list at the minute? Is it are you feeling that breadth already or not? Anybody dare to speak, or do you want to stick it in the chat? Is there anything you could give us some examples maybe of stuff that you're being given as part of your role as a band 7, which would fit with those sort of more broader formulation, evidence-based service development type skills?
Maybe sometimes it's about asking for that, because I think sometimes people will, it's that double bind, isn't it? You're sort of seen as newly qualified, so you ought to know what you're doing, but then you're not given the opportunities because you're supposed to be consolidating what you should know. And both those things apply. So
true. I would say that my psychology colleagues have been quite supportive, encouraging me to settle in, not take too much on. I think someone said, don't expect too much of yourself for the next 12 months, which was really nice and quite reassuring. But I'm working in a CMHT where there isn't another psychologist in the team, and so I feel like I'm being asked to do lots of those things that are part of our role by other professionals, because that's how maybe they see psychology, which is fine, and I'm happy to do that. But there seems to be a bit of a difference between what psychology is expecting of a newly qualified and what the rest of the team is expecting.
That's really interesting. And that thing about that, often we're going into teams newly qualified at really quite senior bandings compared to colleagues, aren't we? So in terms of that sort of expectation of leadership from colleagues quite early on, that's an interesting one. Have other people found similar tensions or other challenges?
Yeah, I've had similar difficulties in the team that I'm in, where other professionals are asking psychology to do things, and we've got a new assistant, we've got a couple of new trainees from Liverpool as well, and they're asking them to do things that perhaps isn't appropriate for their development. So we've decided that we're going to develop sort of a psychology pathway almost, just to make it a bit more clear about what an assistant does, what a trainee does, what a third year trainee does, what a newly qualified does, just to make sure that everything's clear, but also the needs of the service are being met. Because I work in a learning disability service, so we've had to do a lot of adaptation to like the waste assessments to make sure they're safe to be delivered in a socially distanced way.
Interesting. So trying to clarify, because that's a good point, isn't it? Like Geeta said, if we can't explain it, how can others understand it? Yeah. What about other people?
I was just going to say, similar to Emily, I'm in the CMHT as well, and I think there's been like a sort of big recruitment of new starters, so I think the psychology resource has been built up quite a lot, but I've kind of picked up a waiting list, an existing waiting list off the previous psychologist who just retired, and we've met and we've kind of talked about how it works. But I think as a first thing for me, I feel like I've been really sheltered and protected from waiting lists. I just don't think you really kind of deal with them as an assistant and a trainee. I think you just, I know for me, the teams I was in, admin or kind of the team overall had a waiting list and you just got your caseload from that. But yeah, this is now my own waiting list, so kind of all the targets and everything else. And I think just the way that the previous psychologist worked, it just meant that it was kind of always an ongoing, open, you could just access psychology sort of when you wanted, which has meant that the waiting list is very, very long. So it's kind of, I'm coming in saying, actually, I'm not going to work like that because it's not working, which is really difficult for the team because they're saying, well, they used to just be able to come back for more sessions whenever they wanted. And you think, oh, I know, but I don't know if that works very well. So
there's that opportunity to put your own stamp on things, but then the potential tension with the demands from other people and expectations that might be different. So potentially having to have some quite difficult, challenging conversations right at the start. Yeah. In a way that keeps staff engaged with you, but can help you.
Yeah, definitely. Which is probably not really in my nature either. I'm much more of a, that's fine, I'll just do that. So it's kind of,
I think a lot of us can identify with that.
Yeah.
Especially Sophie, given that I really identify with what you're saying, that this is just not something you have to deal with until day one of qualified life, is it?
No.
And I can reassure you that it's probably the most talked about thing for me 15-20 years later with my colleague about what on earth are we going to do about the waiting list, how are we going to prioritise people, is this fair, is it working, should we assess people first, should we I can honestly say it's probably the biggest professional dilemma still, but you don't really grapple with it until now, do you, in a way?
No, I know. I just got handed this Excel spreadsheet and me and Excel are not friends as it is, so that was a task to begin with. But it's just like and I think that's just the way the CMHTs work in our particular sort of hub, that every psychologist has their own waiting list and works it that way. So there's pros and cons to it, but
it might be one to think about these when we're chatting. Note down some of these ideas for what you might want in these future sessions, what might be useful, because we're going to come to that at the end of the day, at the end of the morning.
I think it's also useful for feedback for us as well, so thinking about the final year and what, how we can incorporate things into teaching and placement experiences potentially that will help with this transition as well. We often talk about it as that year 4, at the end of training, and there's a lot of stuff that we can learn from you as well and feed into that process. Okay, right.